Looking at all of the latest IOLs when we go to our national meetings and at ASCRS last spring, I heard of this new lens come out by the influence and sort of direction of Dr. Graham Barrett, who, of course, has brought us some of the most accurate formulas and wonderful precision and everything else I followed throughout my IOL calculations up to this point. Sort of excited to hear something that might provide more range for my patients, but a little less noise and complaints with nighttime difficulties. Usually I come out talking about the patient's needs. Many patients have zero difficulty with readers. I've been using those since age 45. I say, let me turn you into a wonderful permanent 45-year-old that has terrific distance vision, but we'll still need some readers for the small stuff. And many patients are happy with that. However, this day and age, as we're Zooming right now, sometimes it's really nice to see your computer screen, your dashboard, your mid-range, your cell phone, that people can change the font, but they still like some range, inside of 20 inches. So I typically go for the dominant eye for the best distance I can. And then I do my eyes typically about 2 weeks apart. So when they say to me, hey, this is terrific, I can't believe how good my distance vision is, and my range is fine, I'll do the same thing on the second eye. Versus if they say, boy, I wish I had a little more near for what I do, I might target somewhere between a -75, -1 on that non-dominant eye. And of course, remember with the DMV, whatever you target, you are likely to get 1 1/4 more near range than what their actual refraction is. So that's fantastic. That's the extended depth. That's that extra little spherical aberration in the center that's giving you 1 1/4 more range than you would have with a standard monofocal. It's a great question. I think when you're first starting off, you should probably implant a bunch of patients somewhere around the plano for the dominant eye. And on the non-dominant eye, really small, -1/4, -1/2, unless they've come to you prior and say, I've done 10 years plus of monovision contacts and I know what I'm talking about, that's fairly safe to go towards a mono range. But instead of killing their distance on that non-dominant eye, so to speak, with say typically a monofocal calculation of a -2, then that eye will only see maybe 2,400 in the distance, right? But you can calc them a -1, -75 with the EMV in their non-dominant eye. They'll still have 225 worth of reading, that extra 1 1/4 you get with this lens, but now their distance will be maybe 20/60, and they'll have so much more blended vision and better depth perception. So for beginning surgeons, plano on the distance, maybe -1/4, -1/2 on the non-dominant. If you know you're sort of growing up to the monovision, or the patients have had that experience, that's when you start going maybe more than -1 on the non-dominant eye. So wonderful, not perfect contrast measurements, but in patient satisfaction survey, real world sort of answers from the patients. We had actually done a study that we submitted to ASCRS with 30 patients with the EMV and 30 patients with a standard monofocal acrylic lens, excellent distance vision on both. When we talked to them about both positive and negative dysphotopsia, so lights off to the side, difficulty with driving at nighttime, or shadows off to the side, which we know are very common in the beginning stages with almost any intraocular lens. The results were exactly the same. No increase in noise to their vision or difficulty with nighttime driving, difficulty with distance at all compared to my best version of a monofocal lens that I've been using. So far, when we did our first preliminary trials that we've actually recorded, and everyone was targeted for a plano to -1/4 in both the monofocal group and the EMV group. We had, sort of we sort of had set off the charts satisfaction with distance in both groups, and that's great. And the modern formulas and topographies make the doctors look smarter, so it's nice that we're achieving excellent distance vision. But when we checked for their intermediate and near activities and sort of listed your dashboard, your PC, and your cell phone, because we thought that those were pretty common things that most patients have been commenting to us about over the time. We had over 80% of patients in the EMV group being very happy with their intermediate to near tasks without glasses. And this was targeted for Plano. I hadn't started doing more of the mini mono yet, compared to a little less than 50% satisfaction with the monofocal group when you talked about their intermediate or near activities. So almost double the patient satisfaction with really the same calculations. The more procedures you do, the more you'd love to over-deliver and under-promise. And I usually do start off saying, I'm not sure that anything quite makes you a perfect 20-year-old yet, but I think we can do a little better than the average 45-year-old. And for those of us, myself included, that are now north of 45, it does seem reasonable to say, give me excellent distance and pretty darn good functional vision. And to me, that's the food on your plate, your shampoo and conditioner in the shower, your dashboard, your PC. If I can give that by setting that dominant eye for distance, having them give me the feedback at the 1 week visit when it's already done, slight majority of patients saying, this is already great, just give me the same thing on the other, I can already do those intermediate and lifestyle ranges, then I give them the same calculation on the second eye. If in fact they say, boy, I wish I had a little bit more near, I cheat a little bit, I have the blended vision. With the EMV now, I'm not losing any depth perception by doing standard monovision, one locked for distance, one locked for near, then they need, 70% of folks love mono, and maybe 30% of people find it difficult to adjust to over time. When you do a blended, you're not losing that depth perception, you're not losing the distance, but you're still getting the same near vision that you would in the past with large differences in calculations. So I think that the patient can teach us what to do, and this is a wonderful tool in the toolbox to kind of on the fly give them what they need. So what I would say to surgeons that, sort of look at the data and say, oh, and another new lens that's maybe promising the world, well, come out and really try it, because although it's talking most about how you can be set for mini mono vision, which much better depth perception, more range, the near eye, having in fact still fairly decent distance vision, but getting that same reading you would get when you'd otherwise have to set them for a -2.25. Now you can set them for a -1 and get that. That's wonderful, and it's delivering on everything that it's advertised. But what I've been most surprised and impressed about is listen to what they tell you about their distance. We're used to nailing pretty close to Plano with so many monofocal lenses. But I've never had a lens before the EMV that I hear so many unsolicited comments and, no, doc, you don't understand. My distance is really good, like high definition, really good. And it's kind of strange when that many patients have told me this sort of, again, unsolicited, with how happy they are with the part I thought I would nail anyways, but what do you think of the near? Oh, no, the near is great, but I just still can't believe how good my distance is. So it's really not just for mini mono. You're really helping everything.